Thank you, Dr. Krishnan, and good morning, everybody. May I have my presentation on this? This is another talk in this particular series. I've been assigned the task to talk about malignant ascites of occult primary, the evaluation and management. So coming to this, malignant ascites, as we all know, is a manifestation of an end-stage events in a variety of cancers and is associated with significant morbidity and early mortality. Its onset and progression is associated with deterioration in the quality of life and a poor prognosis. Traditionally, all these have been regarded as an end-stage disease which was only amenable to palliation till now and systemic chemotherapy. The things are now changing as far as management is concerned. There has been a nihilistic attitude towards this condition. This is probably the second most common cause of death after hepatic metastasis, as Dr. Chaubal has just said, that it is prone to frequent hospitalizations because of recurrent obstruction in intra-abdominal infections, and probably it is virtually incurable. The things are now probably changing with some newer modalities of management. Average life expectancy was 6 months after development of malignant ascites. Now with best systemic chemotherapy, the median overall survival has gone up to 20 months and median disease-free survival around 10 months. There has been a poor literature on the effective treatments. This is very important because these patients have often been excluded from clinical trials because they have probably a non-measurable disease. Large number of malignancies have been known to produce malignant ascites, almost all of the malignancies. But if you look at an overall situation, there are certain ones which are very common. The gynecologic malignancies, the GI malignancies, the breast cancer, and these are the three most important ones which produce ascites. And then you have number of situations where you have malignant ascites developing secondary to cancers or unknown primaries. It is important to know a little about the pathophysiology. It's not that just peritoneal metastasis develops, you have the exudation of fluid in the peritoneal cavity, blockage of lymphatics, giving rise to ascites. There are a number of factors which can play a role in genesis of these ascites. Information is important for us to understand. Is important because there are a number of new targeted therapies which are targeted towards different mechanisms of formation of ascites. So that is there. The liver metastasis is another one, the portal vein obstruction, cirrhosis with secondary malignancies, of course, genesis is different. Number of local and systemic inflammations can result in exudation of fluids. Many patients may develop heart failure, and pancreatitis may also be contributing to this ascites. Now it is important to know that there are certain compounds which have now been found to have, there are certain components like tumor cells have been found to produce what is known as vascular endothelial growth factor, which results in more angiogenesis, increase in permeability. So you have now targets against this particular mechanism also. You have metallic, so-called MMX of the metalloproteinase, which is produced by many of these tumor cells, which results in breakdown of the matrix and can result in further dissemination of tumor cells. So all these mechanisms are important subsequently to identify various targets of treatment. So if you look at the overall situation, peritoneal carcinomatosis is responsible for 53% of the cases. Massive liver mets producing portal hypertension 13%, hepatocellular carcinoma plus cirrhosis 13%, and there are so many others also. So different mechanisms work in different situations. So in patients with malignancy-related ascites, almost 2/3 have peritoneal carcinomatosis, while 1/3 of the non-malignant causes are there, so secondary portal hypertension, or lymphatic obstruction. Like if you have cirrhosis, if you already have a liver with extensive metastasis, the ascites which develops behaves exactly like that of portal hypertension. And lymphatic obstruction can produce what is known as scalous ascites because of obstruction of lymphatics in peritoneal cavity. So how do you evaluate? You have to find out whether the ascites is malignant or non-malignant, and if malignant, what is the primary. If you look at this, starting off with patients with ascites suspected or established malignancy, you have to do certain important things. The diagnostic paracentesis is one of the most important things. Get a serum albumin. Abdominal imaging like CT scan and MRIs, ultrasound examination are all very important. By and large, patients who have carcinomatosis or peritoneal carcinomatosis have an ascites which is a low-grade ascites, less than 1.1. That means serum ascites albumin difference is less than 1.1. In those situations where portal hypertension is contributing to development of the ascites, like liver with extensive metastasis, this gradient is high, behaves just like cirrhotic ascites. It is important to know this situation because the patients who are given diuretics probably in malignant ascites, Those who have low-grade ascites, they respond very poorly to diuretics compared to the others where diuretics may be useful. So looking at this, the overall simple evaluation of the ascitic fluid that we do otherwise, the most important thing to be done is cytology. Overall sensitivity of this cytology is for detection of malignancies around 75%. It is very high in those situations where you have peritoneal carcinomatosis, but in those situations where you have liver mets with ascites formation, usually a cytology is universally negative. It also depends on the amount of fluid that you send for evaluation. Around 50 ml minimum is required for one specimen. And not only that, there is an incremental benefit if you send more and more samples. Like first sample specimen, 83% positive, with three samples, for example, almost 97% will be positive for peritoneal carcinomatosis. Now there are certain very unproven and unhelpful tests. You will remember that in clinical practice, most of the time we see for CA125 or CA, for example, in ascites. Sensitivity and the specificity of CA is very limited, and the precise value for ascitic fluid CA levels in diagnosis and differential diagnosis is very uncertain. Do not measure ascitic fluid CA levels. Similarly, CA125. Virtually all patients, including men with ascites or pleural fluid of any cause, have an elevated level of CA125. Similarly, the assays for ascitic fluid CA125 are not very helpful for differentiating between ascites, which is due to ovarian cancer, and the ascites that is due to tumors or benign causes. So do not test the patient with ascites for CA125 either in the serum or in the ascitic fluid. This is important for all the clinicians because in clinical practice most of the time this test is done. There have been several humoral tests which are suggested for malignancy like fibronectin, glycosaminoglycan. They have all been proposed to replace the supplement cytology, but none have these tests have stood the test of time and they should not be done. There have been other tests also which can be done to differentiate malignant and non-malignant ascites like salicylic acid levels, HCG beta levels, vascular endothelial growth factor levels, telomerase activity, so on, but they are all experimental and none of them has gone from bench to bedside. Laparoscopy is one of the most important. With biopsy of the peritoneal implant, it has sensitivity of detecting this carcinomatosis in almost 100% of the cases. It is specifically required for the diagnosis of peritoneal mesothelioma, where ascitic fluid cytology many times is misleading. Similarly, a mental biopsy, which can be CT guided or CT or ultrasound guided, can be done to detect malignancies. In spite of all the investigations, almost 20% of patients have so-called tumors of unknown primary origin. They have ascites of unknown origin, with where the primary is not known. Now, advances in imaging and immunocytochemical analysis will continue to influence a decline in the number of cases of malignant ascites associated with carcinoma of unknown primary. That means advanced imaging and immunocytochemistry or immunohistochemical studies are playing a major role. Laparoscopy with a biopsy is a safe and a minimally invasive technique and helps to establish primary tumor diagnosis. It is particularly in the females with the poor performance status who have with a good performance status who have no apparent cause for ascites. I will not go into the details. Initial diagnostic evaluation of patient with cups is just like what Dr. Chaubal has just mentioned, a complete history and physical examination. Various imaging studies are done in these situations. One should try to obtain a biopsy and a generous biopsy, if possible, when you are doing a laparoscopy, because you need to do not only histology, but various immunohistochemical stains, various molecular studies, etc. are required in these situations. After doing ICs and ICCs, there is something called now molecular cancer classifier assays, which can be done on very small biopsies, experience cytology, etc., and which can certainly give you a very good idea regarding it. So I think now, as far as cancer of unknown primary is concerned, availability of so many molecular assays and so many advanced technologies have resulted in gross reduction in a number of those particular cases. So you can diagnose most of them. If you look at the molecular cancer classifier assays, there are several which are available. I don't know how many are available in India, but at least 3 of them are available in America, where they do certain genetic tests, RT-PCR, and can detect almost 15, 50 or sometimes 49 cancers very easily by doing these particular tests. So especially in those situations where IC or ICC has not been able to achieve that, these molecular genetic classifier assays can be performed. Now, depending on IC patterns, characteristics, single cancer tissue, you can identify various kinds of malignancies. I will not go into the details. Like you have different molecular signatures for different types of malignancies. So if they are there, you can direct your evaluation to that particular organ. This is an interesting study which was performed and suggested by some Koreans, I think. It was probably from Korea. This was a diagnostic algorithm detecting primary tumor sites using peritoneal fluid. This was conducted to develop a novel algorithm for determining origin of tumor by combining analysis of cluster patterns with immunocytochemistry. And the cluster patterns means if you do, for example, this is done basically by using what is known as liquid-based cytologies. You do a molecular analysis and you do immunocytohistochemistry in this cytochemistry in these particular situations. What are you going to do then? The morphology of different malignant cells is well eaten in this particular situation if you do a liquid biopsies. There are no artifacts in that particular situation, no debris seen in that, and this thing. And many of these malignancies, different malignancies, form different kinds of three-dimensional clusters in the ascitic fluid. Evaluation and assessment of these clusters is very important. You can detect, oh, you can suspect, well, this particular cluster suggests gastric carcinoma, this suggests ovarian carcinoma, like that. You can see here, like stomach and all these things, you have no clusters in gastric carcinomas. Lungs, you have predominantly very small size clusters, pancreatitis, small size clusters, and so on. Similarly, you have different kinds of other conditions also, like ovary and colon, all these things. And this is how they look like. You can see here the stomach, hardly any clusters are there. A slide, B side is the lung, C you can see here the pancreatibiliary tract, E is the breast, and F and this thing is colon cancer, and E is ovarian cancer. So these are different kinds of clusters that you see. So for an experienced person doing a cytology like this, he can easily say that probably I feel that it is coming from this particular site. Similarly, you can do certain staining for certain markers, like you have cytokeratin 7 or paired box gene, for example, 8. You have different types of stains for this. They may be positive or negative in different kinds of malignancies. So based on this, they have suggested a kind of an algorithm. This is very interesting. You have atypical still seen on this thing. You do a CK7 staining. If it is negative, look for the 3D cluster. If there is nothing is there, this thing, it is negative malignancy. If it is yes, it may be colon or unusual metastatic tumor. If it's a CK7 is positive, look at the 3D cluster. If there is no 3D cluster, probably it's from stomach. If there is a 3D cluster and PSK, the paired box gene 8 is positive, it may be from ovary. If it is negative, it may be pancreatitis, stomach and breast and all these things. So that is the situation. So that is how the things. The battery is running low. I don't know what is this. This is not coming further. Yes, battery is running low. So depending on these markers, etc., you can use different types of modalities for evaluation also. Like previously we used to do blind gastroscopies, colonoscopies, bronchoscopies to detect primaries, but these days it is no longer recommended. You have certain clear-cut molecular signatures there, and you can direct your investigations according to that. So this is how it is. So coming to the prognosis, presence of ascites has strong negative prognostic import. It is different for different malignancies. One retrospective study reviewed experience with the malignant ascites over 10 years. What they have found is the GI malignancies were associated with the poorest prognosis. For gastric carcinoma, 1.5 months, pancreatic 1.4 months, and colonic cancer, it is 3.7 months. The best is probably for a properly treated ovarian cancer. There have been various prognostic factors which are for the non-ovarian cancer groups, which are a poor prognostic factor. The low serum albumin, presence of liver metastasis, and markedly elevated serum bilirubin. Coming to treatment, I will not go into the details. Majority of the treatments that we manage actually of malignant ascites is by repeated paracentesis in diuretics. Diuretics, as I already said, work better in those situations where you have a high gradient ascites, but do not work well in low gradient. So overall efficacy of diuretics is hardly 45% compared to almost 85% of cirrhotic ascites. To obviate the necessity of repeated paracentesis, peritoneal venous shunting has been recommended. It also has several problems. Some people do it, and most of the places it has been given up. Then you have something which has been done by Japanese, the so-called CART, that means cell-free concentrated ascites reinfusion therapy, which is being practiced at several places. What has really made a difference is the presence of intraperitoneal chemotherapy, where a high cytotoxic concentration of active agent is, where it is infused in the peritoneal cavity, it remains in a high concentration in the abdominal cavity with minimal systemic absorption and systemic toxicity. Clinical trials have shown that patients of ovarian cancer have shown intraperitoneal therapy to be superior to the systemic chemotherapy compared looking at the progressions of survival or the median overall survival. The studies have also shown that the combination of a systemic and an intraperitoneal chemotherapy was more effective than the exclusively intravenous treatment. Now, what has really made a difference, I think, is this: cytoreductive surgery plus HIPEC, or the hyperthermic intraperitoneal chemotherapy. This is a new standard for treating peritoneal surface malignancy. I'll just mention out the principles, that's all. What is done in this is cytoreductive surgery means you have to resect all the visible or the macroscopic disease which is more than 1 millimeter in size. And subsequently, the chemotherapy has an ambition to treat the remaining non-viable or the microscopic disease. That means you do a surgery, followed by that you infuse a particular drug, chemotherapy solution, which is heated between 141 to 43 degrees centigrade. Infusion is done for about 30, 90 or 120 minutes, and it keeps circulating in the peritoneal cavity. The results have been found to be very good. This concept, this therapy was done for pseudomyxoma peritonei way back in 1980 for the first time. Sugar Bakers has done a lot of work on this particular thing. What he has mentioned is peritoneal metastasis should not be considered as a generalized disease. Involvement of peritoneal surfaces may occur in the absence of hematogenous metastasis or may represent the dominant clinical picture. This peritoneal metastasis should be considered as a locorenal disease. That is why you have to do a cytoreductive surgery in these situations. Treatment of macro, you do a cytoreductive surgery. Peritonectomy procedures are performed in these situations, and for microscopic disease, you give a heated intraperitoneal chemotherapy. You may treat a system by giving a systemic chemotherapy also in these particular situations. So this is a kind of a roller pump that you use for this thing. There are different methods: the open method, the closed method. You can do it during the surgery, immediately after surgery, or after 3 to 4 days after the surgery. Heat, what is the importance of heat? Heat synergizes the effect of chemotherapy. It helps in the penetration of this drug in the cells. It reaches a high concentration in the peritoneal cavity, remains there for a long time. Several drugs have been mentioned in this. I will not go into detail, but gemcitabine, carboplatin, mitomycin C, and so many of them in different combinations or alone have been used. Best conditions to be treated are pseudomyxoma peritonei, peritoneal mesothelioma, primarily from the colorectal, small bowel adenocarcinomas, like that. Should not be done for ascites developing pancreatic malignancy, bile duct gallbladder. Can be done for ovarian cancer or gastric cancer. So that is what is mentioned here. I will not go into details here. So in summary, malignant ascites, though represents a small proportion of ascites, have poor prognostic implications. Many options are employed, but no randomized control study to compare the effectiveness. Abdominal centesis and diuretics, however, remain the mainstay, as happens everywhere. That is what we do. Cytoreductive surgery with HIPEC is a promising treatment for certain cancers. There are several novel approaches that may be considered experimental, like using certain VGF antagonists are there. You do certain immunomodulators that you instill in the peritoneal cavity, and there are so many other drugs also which are being tried, but they are all experimental. Thanks.